Hello everyone, I'm Claudia and today I will be presenting the CE course Oral Health Care and its Relationship with Pregnancy. Course description, Oral Health Care and its Relationship with Pregnancy. This is a 1 hour on-demand continuing education CE course developed for dental professionals, particularly dental hygienists and dentists, using evidence-based research. This course will equip you with the skills and understanding needed to effectively address the oral healthcare needs of pregnant patients. You will explore physiological, oral, and systemic changes that occur during pregnancy, review current safety guidelines, and learn how to address common misconceptions held by both pregnant patients and dental providers. You will first complete a pre-test, and then upon completing the CE course, you must complete and pass the post-test with a score of 80% or higher to receive your certificate of completion. Introduction. Receiving optimal care during pregnancy, it is important for the well-being of both mother and baby, yet oral health care is a topic that is often overlooked during this critical time. As dental healthcare professional, we might find this subject intimidating or difficult to address with pregnant patients, which can lead to negative consequences for both mother and child. In the US, fewer than 40% of pregnant women seek preventive oral health care, leaving them at increased risk for gingivitis, periodontitis, cavities, and other health issues that can worsen during pregnancy. This continuing education course was developed to close the gap by equipping dental professionals with current evidence-based information and the communication tools needed to effectively support their pregnant patients. Learning objectives. First, identify the physiological, oral, and systemic changes that occur during pregnancy and its impact on oral health. Apply specific trimester guidelines when delivering treatment or providing knowledge to pregnant patients. Evaluate the safety guidelines of dental products, anesthetics, and procedures during the different trimesters. Increase awareness of common dental misconceptions for dental professionals and patients. Increase confidence when treating a pregnant patient by using effective communication, documentation, and evidence-based patient education. So I will be addressing some common misconceptions that I have personally heard and that are often seen in pregnant patients. And then we will go over of why it is important to address these misconceptions and how to improve patient care and give them the information that is best for them. So the baby takes the calcium from the mother, and if you don't get enough calcium, the baby will take it from your teeth. Never get dental x-rays during pregnancy because it can cause complications. I would say this is the most common misconception that I've heard and encountered as a hygienist. Then third, dental treatment should wait until after the delivery because local anesthetic and the process is not safe neither for the mother or the baby. Dental cavities or losing a tooth is caused by the lack of calcium. And finally, dental visits are not necessary and should be avoided during pregnancy. And now I'm gonna be addressing some physiological changes. So hormonal changes, specifically increases in progesterone and estrogen levels during pregnancy, raise the risk of gingival inflammation and cavities. Progesterone can weaken immune defenses, reducing the body's ability to fight off bacterial plaque. Estrogen, on the other hand, can reduce keratinization of the gingival epithelium, increasing susceptibility to bacterial infection and intensifying the vascular response. This makes estrogen a significant contributor to pregnancy gingivitis. Additionally, these hormonal shifts can create an environment that favors the growth of periodontal bacteria. Behavioral and dietary changes also play an important role. Dental erosion is commonly caused by vomiting during morning sickness, which repeatedly exposes the teeth to stomach acid. This weakens the tooth enamel and increases the likelihood of developing cavities. Reduced saliva production during this period further elevates the risk of both dental erosion and tooth decay. It is important to know that while this information is something that we learn in school, it is still important to review, as some of us might have forgotten. There's some oral health conditions associated with pregnancy. First, pregnancy and gingivitis. This condition typically peaks during the third trimester. It is caused by an inflammatory response to dental plaque rather than an increase in the amount of plaque itself. Treatment is especially important because women who have experienced gingivitis before pregnancy are significantly more likely to develop it again or have it worsen during pregnancy. Another one is periodontitis. If gingivitis is left untreated, it can progress to periodontitis, a more serious and irreversible condition. This occurs when severe plaque accumulation along the bone triggers a chronic inflammatory response, releasing bacteria, toxins that lead to bone loss, deep periodontal pockets, and in some cases, bacteremia. Not very common. Tooth mobility. During pregnancy, the ligaments that support the teeth might loosen, causing some degree of tooth movement. This is generally temporary and does not result in tooth loss unless the condition advances to a more severe stage. We're going to continue. Pyogenic granuloma. This is benign, highly vascularized, rapidly growing peduncular oral lesion that bleeds easily upon touch and typically appears on the anterior gingiva. It is thought to be triggered by an inflammatory response. It affects only about 5% of pregnant women and often resolves on its own after delivery. So the removal is recommended only if the lesion interferes with eating, causes severe pain, or results in significant bleeding. Another one is dental erosion, which we can see in the picture at the bottom. Is morning sickness is particularly common during pregnancy, leading to more frequent exposure of the teeth to gastric acids. This repeated acid exposure can result in the permanent loss of tooth enamel. Lastly, dental cavities. Pregnancy itself does not directly cause cavities. However, several associated factors can increase the risk of developing them. These include heightened of oral acidity from frequent vomiting, increased snack consumption due to pregnancy cravings, broader dietary changes, and a potential decline in routine oral hygiene practices. Periodontal disease and adverse pregnancy outcomes. Severe studies have confirmed that periodontal disease is adversely linked to health complications during pregnancy, including premature birth and low birth weight. Patients with periodontal disease show significantly greater plaque buildup, gingival bleeding, and overall gingival inflammation during dental exams compared to patients with healthy gums. Premature birth was more common among patients with periodontal disease, with more than half delivering early compared to those with healthy gums. Approximately 70% of babies born to mother with periodontal disease had a low birth weight. So, periodontal disease and adverse pregnancy outcomes. How or why? Periodontal pathogens present in the mouth can enter the bloodstream and travel throughout the body, including to the placenta and uterus. The bacteria and their toxins that trigger the body's inflammatory response, releasing chemicals such as interleukin 1 and promoting systemic inflammation. These pro-inflammatory chemicals might stimulate a uterine response or affect the placenta, potentially causing the baby to be born earlier than expected. So as previously mentioned, elevated hormone levels can also worsen gingival inflammation and increase blood vessels permeability, making pregnant women more susceptible to gingival disease. So we're going to address some of the physiological changes. So how to address some of these changes? It is important to discuss these possible changes to pregnant patients. That way they understand and are aware of the changes in their body and how to also solve this or prevent these issues in order to prevent possible complications. So, pregnancy and gingivitis. Recommend rinsing with warm water and salt might help relieve gingival irritation. It is also worth advising patients to floss more frequently, though it is important to acknowledge that this might trigger some gag reflex difficulty alongside their regular oral routine. Um, Another is dental erosion. Recommending rinsing with a cup of water containing a small amount, like about a teaspoon of baking soda, can also help neutralize acidity in the mouth. Patients should be advised to wait at least 30 minutes after vomiting before brushing their teeth, as brushing too soon can spread the acid across the tooth surfaces. Clinical guidelines. So, currently, clinical guidelines emphasize that preventive, diagnostic, and parental procedures are safe to perform throughout pregnancy. Delaying treatment might lead to more complex issues. That said, certain considerations should be kept in mind when treating a pregnant patient. So, we're gonna go over trimester specific considerations. So, for the first trimester, which is weeks 1 to 13, during this stage of organogenesis, most patients experience frequent nausea, vomiting, and an enhanced gag reflex. Dental procedures are generally safe to perform during this period. However, if the patient is experiencing significant discomfort, it might be best to postpone elective treatment. So, recommended care. Avoid scheduling morning appointments when nausea tends to be at its worst. Educate patients about the oral changes that commonly occur during pregnancy. Discuss the importance of maintaining good oral hygiene, including proper brushing and flossing. Lastly, prioritize emergency appointments and address infections or sources of pain as promptly as possible. Second trimester goes from weeks 14 to 27. Um, this second trimester is generally considered the most comfortable period for dental treatment. Nausea has typically subsided and organogenesis complete, and the uterus has not yet grown large enough to cause significant discomfort in the dental chair. So, supine hypotension is also uncommon at this stage. The recommended care: ideal for routine checkups, elective dental treatment, including root canal extraction and SRP. Third trimester, it goes from weeks 28 to 40. As the uterus continues to grow, the supine position might cause some discomfort and carries a higher risk of supine hypotension. Short appointments are recommended during this stage. Recommended care: preventing emergency dental care should be continued as needed. To prevent supine hypotensive syndrome, position the patient with the left lateral tilt or a semi-reclined position. Dental radiograph. The ADA and ANCOG state that dental radiographs are considered safe at any stage of the pregnancy, and using a shielding to protect the stomach and the thyroid is no longer needed because there's no scattered radiation. These images are important to take for risk assessment and any clinical findings. This radiograph will even include the full FMX, which generates approximately 0.001 MSV, which is far below what it would be considered unsafe for the developing fetus. If you want to reassure the patient, first explain how safe radiographs are to take, then in cases of continued denial or uncertainty, place the lead apron and offer an additional one to reassure. Personally, this is one of the most common questions I get in the office from patients and even other coworkers, dental professionals. Um, which at first, when I started, I keep doubting myself of what was the correct answer. Of course, safe all the time now. Um, so we're gonna continue with dental radiograph. Having a sheet with a safety information and explanation to give to the patient will save some time not to inform the patient about how much radiation they are receiving. For example, I have here an image that could be very helpful for to show patients and explain how much radiation they're actually getting from x-rays. So, for example, if I single dental x-ray by Wayne is equal to 0.2 USV and a long fly is 40 USV, then they will need a pregnant person will need 200 dental x-rays to reach the equivalent of a single fly. So, to summarize, it is safe to take x-rays, even an FMX during the chair. If the person still has doubt, double shield, and that way the patient feels more at ease and the appointment can go more smooth. So now we're gonna talk about anesthetic safety. This information has not changed in many years, but this will help as a review. So anesthetics, lidocaine 2% with epinephrine. It is the preferred local anesthetic, recommended to use the minimum effective dose and reduce stress hormones to adequate pain. Articaine 4% with epinephrine, reasonable second line of option, but lidocaine is still the safest option as articaine can cause fetal mortality and skeletal deformities in animal testing. Use only if the benefits are greater than the risk. Mepivacaine, avoid or use with caution because it is associated to methemoglobinemia during the first trimester and even during lactation due to the preservative used for stabilization. Medication safety. These are common medications that we use in the dental practice. And fluoride is one of those that many dental professionals are still questioning its safety, especially since the information provided is scattered among and there's still lack of research, especially for fluoride in pregnant patients and its possible effects on the baby. Some people are still skeptical about the fluoride alone, so this information is important to have into consideration when medicating patients. So first, we're going to talk about nitrous oxide oxygen. It should be avoided due to the risk of fetal harm with prolonged exposure, particularly during the first trimester. It is considered less concerning during the second trimester. And fluoride. Fluoride varnish topical. Generally considered safe during pregnancy and is strongly recommended for cavity prevention. It is worth noting that fluoride gel should be avoided as it might cause nausea in some patients. Then we have prescription toothpaste, 1.1% sodium fluoride. It is recommended for pregnant patients at extremely high risk of caries. Current evidence suggests a low risk of harm to both the mother and the fetus. Then we have chlorhexidine gluconate, 0.12%, considered safe for use during pregnancy, but patients should be instructed not to swallow it. And we continue. Medication safety, amoxicillin, generally considered safe during pregnancy. If there is any uncertainty, consult with the patient's OB before prescribing it. Ibuprofen NSAID avoid using during pregnancy, particularly in the third trimester, as it can cause premature closure of the ductus arteriosus. Use acetaminophen as an alternative for pain management. Tetracycline, doxycycline avoid use during pregnancy as these medications can cause permanent tooth discoloration and inhibit bone growth in the fetus. So it is important as dental professionals to be aware of this common medication and its safety as we often see it in the office. Even if we're not allowed to prescribe it, being aware of the situation can help to patients and us, of course. Oral hygiene instruction. So, general dental hygiene instruction, while these oral hygiene instructions are similar or the same that we provide to regular patients, it is important for us, especially dental hygienists, to emphasize the importance of actually doing this. So, for toothbrush, brush teeth using fluoride toothpaste twice a day, morning and night. Change toothbrush every 3 or 4 months. Do not share a toothbrush and a smaller headed brush in case of a gag reflex. We're gonna continue with the oral hygiene instructions. So, clean between the gums and teeth using floss or an interdental brush. Choose xylitol gum. There are now many products containing xylitol that are safe to use during pregnancy, such as mouth rinse, or as I have here, Xylomelt. It helps with the dry mouth and also cavity prevention. To help neutralize acids in the mouth, dissolve a small amount of baking soda, about 1 teaspoon in water, and use it as a rinse. This can help with reduce the risk of cavities and dental erosion. Now we're gonna talk about safety of some products. These are some of common products that some dental offices might use for different reasons, such as periodontal disease, gingival inflammation, or prevention of cavities. You might or might not find it in the office that you're working at. So, first, POVI1, 10% iodine topical solution. Not safe during pregnancy as it can cause neonatal hypothyroidism. Arrestin, which is used mostly when there's deep pockets or after SRP, are not safe because it contains tetracycline, possible causing permanent discoloration on the teeth during development. Glosses mouth rinse. I would say it's very common mouth rinse to find in offices and recommend to patients. Control bacteria and reduce the gingival bleeding. It is recommended and safe to use for pregnant patients. Teeth whitening. It is generally not recommended and is as it is a cosmetic procedure. So waiting until after birth and lactation is the best idea. You don't want to do anything extra, especially because it can cause some sensitivity and discomfort afterwards. So best to avoid it. Oral cakes. It contains lidocaine gel. Use for with caution and only if benefit outweighs the risk. Nutrition counseling. This also might help as a review. So, vitamin C helps reduce gingival inflammation and lower the risk of periodontal disease. Vitamin D supports enamel remineralization during early tooth development. A deficiency might contribute to the onset of periodontal disease. Calcium, essential for proper tooth development. Insufficient intake can lead to reduced alveolar bone density in mothers. Phosphorus plays a key role in the formation of dental and enamel. Folate deficiency has been associated with an increased risk of cleft palate. This is important for us even if we don't have time or enough time to discuss all of this. We just have to look at patients on a case-to-case basis, see what they need. Like if they have more inflammation in the gums, just recommend vitamin C. Hey, just tell the patient, hey, you just need, you know, what is your like ask if they eat a lot of oranges or what do they do, or to kind of see what the patient needs are first instead of giving a whole list of vitamins that they need. Um, that will be the best option if you don't have enough time in the chair. So, patient communication. Although these communication skills are something that can be applied for all patients, it is important to keep in mind for pregnant patients, as it could improve the communication gap and help the patient to feel at ease and us to feel like, okay, we're doing a good job, we're doing what we can. So, improving the communication gap between providers and patients can help address certain misconceptions about the safety of dental appointments, including fears about dental procedures and the potential harms of radiographs to the fetus. These misconceptions contribute to low utilization of dental services. In order for the patient to feel more comfortable, providers must be equipped with evidence-based research and demonstrate confidence and knowledge about dental procedures. So, a study found that approximately 30% of dental faculty reported concerns about liability when treating pregnant patients, and that fear of malpractice was a stronger barrier to treatment than gaps in knowledge. So, I will start with some key communication strategies. So, first, we're gonna be patient-centered approach using simple language, positive body language, and visual aids creates an environment where patients feel comfortable asking questions and expressing their concerns. Allowing patients to take an active role in their own decisions rather than feeling pressure can help reduce dental anxiety and build their confidence in seeking care. Adapting care to meet each patient's individual needs contribute to a more positive experience overall, making patients more willing to accept recommended treatment. All of this should take place within the non-judgmental environment where patients feel respected and heard. Correcting myth and misconception. As dental professionals, we have the responsibility to educate patients about the safety of dental procedures clearly, with reassurance and in a cultural sensitive manner. For example, many patients are concerned about x-rays, particularly during pregnancy. In this situation, it's important to begin by calmly reassuring the patient about the safety without being dismissive or forceful. A clear explanation why x-rays are necessary, including the risk of that untreated cavities posed during pregnancy, reinforces the importance of the procedure and supports informed decision making. There are also practical steps such as offering double shielding that can help with patient feeling more at ease. Uh, as previously discussed, not only pregnant patients fear to go to the dentist, but also some providers avoid treating pregnant patients, and one of the big reasons is fear to possible litigation, especially if it's just more than a regular checkup, such as a filling or root canal. So, there are a few approaches that could potentially address provider hesitancy toward treating pregnant patients, particularly regarding liability concerns. First, taking a thorough medical dental history, recording blood pressure, and performing a full dental examination are essential steps. Reassuring the patient that routine dental visits are safe at any point during pregnancy not only builds patient confidence but also reinforces the provider's own comfort with treatment. While these procedures are standard for all patients, it is important not to rush this portion of the visit, as time constraint can sometimes lead to crucial steps being overlooked. So, blood pressure, very, very important. Take it. Second, thorough documentation is key. This include recording the estimated due date, updated medical history, and any reported symptoms such as nausea or vomiting, as well as completing periodontal charts. Providing oral hygiene instruction, noting any clinical changes, and documenting an obstetric consultation if one was conducted. Third, when a pregnant patient presents with complex medical concerns or the provider is uncertain about the safety of treatment, consulting with that patient OBGYN is strongly recommended. Or asking condition-specific questions, such as those related to preeclampsia, gestational diabetes, or hyperemesis gravidarum, can help alleviate provider concern, reduce the risk of treatment complications, and improve overall confidence in managing pregnant patients. Well, these are all sound very basic recommendations. These are practical steps that sometimes, as provider, with the lack of time, overlook. We can overlook the stuff. So, making sure that we're writing down everything, documenting absolutely everything that we can is recommended. Post-pregnancy considerations. So, another thing to consider is safety, not just for the mother, but also the baby's vertical transmission of cardiogenic bacteria. Vertical transmission of cardiogenic bacteria refers to the transfer of Streptococcus mutans from a caregiver, most commonly the mother, to an infant during the first 3 years of life. So these can be prevented by following these recommendations. So first, reduce cavity during pregnancy and maintaining good overall oral health at home. Avoid sharing utensils, cups, and food with the infant. This is something that I often see and I heard patients talking, and we just have to let them know that it is not a good idea to do. Do not clean the pacifier by placing it in your mouth. So let's say it falls on the floor and then you just clean it, like, bad idea. Begin cleaning the baby's mouth and gums with a damp cloth. Schedule the baby's first dental visit after first tooth erupts. Know that pregnancy gingivitis typically resolve on its own after delivery. Very important to let the patient know that. Now, breastfeeding considerations. Local anesthetics are safe, but use prilocaine with caution. Ibuprofen is the preferred NSAID. Avoid aspirin. Nitrous oxide is safe as the body eliminates it quickly. Dental radiographs are safe. Topical fluoride is safe, which is something that I often get questioned by patients, and I usually say that don't want topical fluoride because they're scared that the baby might get it through breast milk. Teeth whitening, there's not enough considering the safety of this treatment, so it is best to avoid it until after breastfeeding. And again, it's very important to consider that teeth whitening can cause sensitivity into teeth, so it just add to the discomfort, especially as a new mother. So that will be it for today's course. If there's any question, please let me know, and you can complete the post-op test now in this survey. Thank you.